HIV focal person in Eastern Southern Africa, based in Zimbabwe. So I just want to start to say that when I went through the program, I found very few titles which have the word STI in it. And I think this is one of the first major presentations we have in the whole of the conference that's really focused on STIs. I've been working in STIs for the last 20 years, and really it's a big issue in my country in South Africa and all over Africa, and especially the adverse outcomes. And one of the key issues for me is infertility, because though we may talk about HIV, we can hide our status and our treatment, but we cannot hide infertility. There are many women who have been suffering from STIs who are infertile, and that's a real issue of stigma for them. So I think we mustn't ever forget that STIs are an important issue in South Africa. So we've got a really exciting session this morning. We have researchers, programmers, we have a number of WHO speakers from around Africa, but we also importantly have a number of community speakers, which I think is very important. So I'm going to start off immediately with Theodora Bui, who's based in Geneva. She's a medical officer there, and her focal area is developing STI guidelines and addressing antimicrobial resistance in STIs. Thank you. The other speakers can go and sit down. The other speakers will just go and sit down now.
So thank you very much for being here. And as mentioned, this is the STI session in ICASA. And I think what for us now is really looking at what I'm going to be discussing at the moment. And of course, you know that for STIs it's much more complicated because we have about 30 different STIs that we need to be tackled. We have the bacterial, the viral, and the protozoal STIs. But the latest estimates that we have for STIs is that there are about 376 million STIs occurring each year. And this is only for chlamydia, gonorrhea, syphilis, and trichomonas. And if you look at it, every day there's about 1 million STIs being acquired. And you know that this is occurring mostly in young women, and they're not disappearing. No, it's not decreasing at all. If you look at it, this is only for the bacterial infection. How about the viral infections? We have about 500 million herpes infections occurring globally, worldwide. And if you look at this, this is about over 1 in 7 women estimated to have prevalent HPV infection. If you look at the current estimates that we have, you look at where the highest burden of STI is, and it is in Africa. We in Africa has the highest burden of STIs, if you look at this chart, both for men and women, followed by PAHO, which is the Latin American countries, and then Western Pacific Regional Office. Looking at Africa further, you know, they did a population-based survey just recently, and this is a community-based survey. And if you look at this community-based survey in women, you note that even chlamydia infection among very young women have very high STI rates. We did a meta-analysis of the different prevalence data that are used in some of these HIV prevention studies that we have in Africa. And you will note that STIs are also very, sorry, I think it's this one. And you will note that STIs, like chlamydia infection, are very high in South Africa and also among high-risk groups. Similarly, gonorrhea rates are high. And even among women that's 24 to 49 years old, very high. But of course, HSV is also as high, and it's increasing when you go older. Of course, STIs, I think, are we losing ground? Look at where even in high-income countries, like in the US and UK, they are already seeing increasing sexually transmitted infections. So it's not just Africa, it's everywhere, it's globally. But another thing that is complicating the increase in STIs is that we are now having a battle of gonorrheal control. We are now having antimicrobial resistance to the last line of treatment for gonorrhea. And if you will note that here, about 50% of countries that are participating in the global antimicrobial surveillance program have reported decreased susceptibility to cefixime and ceftriaxone, which is the last line treatment for gonococcal infection. But what is very glaring in this month is that the absence of surveillance systems for gonorrhea in Africa. You know, we really don't simply know what's happening in terms of antimicrobial resistance of gonorrhea, but overall we can conclude that quinolones should not be used for gonorrhea treatment overall. So what are the major, sorry, it's jumping. Of course, we know that STIs is important. We know for a fact that HPV causes over 500,000 cases of cervical cancer annually. STIs can cause adverse effects in pregnancy. The mother-to-child transmission for syphilis leads to more than 200,000 fetal and neonatal deaths per year. Of course, very glaring is also infertility. In all studies that we have, there's about 75% of infertility in Africa is caused by gonococcal or chlamydial infection. That was in the 60s, but now we still need to, again, look at the data and see how much of it is really caused by gonorrhea and chlamydia. We know that it increases HIV risk, and more importantly, and what we are forgetting is the quality of life. Having an itchy vagina, having a discharge in the vagina, a painful ulcer in your penis, it doesn't improve the quality of life that you have. And most of all, you have psychological and effects in relationship as well. So, but why are we not doing so much with STI control? Why are there issues with STI control? Because majority are still asymptomatic. Majority also, there's a complication of co-infection. You can have gonorrhea, chlamydia, syphilis at one time. Next, we have still limited tools in terms of STI control. We always wanted a point-of-care test, but we still don't have that real point-of-care test, like a pregnancy test, for example, where you dip it and you say you have gonorrhea or chlamydia. So that is still not available. Also, even if we have good interventions, like we recommend in some high resource setting to have screening for young women. But it is so difficult to scale up screening for young women as well. We have problems with now antimicrobial resistance, not only for gonorrhea, but emergently there's Mycoplasma genitalium, which is complicating the whole issue of antimicrobial resistance. More and more behavioral and social factors are also there. We have all these social networks. We now can access our partners through apps, through our cell phones. And we have, again, of course, increasing multiple sex partners. More importantly, we still have low condom use. And of course, stigma and discrimination is always a big factor. When you have stigma and lack of champions, what happens is that there's lack of policy attention, there's limited funding, and of course, when you have limited funding, you have few simple effective STI intervention. So we also need champions. Maybe someone of you can also pose as our champions for our STI campaign. Any volunteers? Yes. And, of course, one of the tools that WHO has always been promoting is syndromic approach. And we know in the early year days, syndromic approach worked. We had lesser genital urethral discharge. Chancroid has also been decreased. But now we need to rethink what we should be doing with syndromic approach. And now we are saying, oh, syndromic approach does not work. So in a community level, there is a real issue of we need more point-of-care tests. For high-risk groups, I think STI screening with a point-of-care test would be important. For women and men attending primary healthcare setup, there's still probably a utility for syndromic management, especially for urethral discharge and genital ulcer disease. But for vaginal discharge, let's forget gonorrhea and chlamydia for vaginal discharge. Treat only for vaginal infection. And of course, we need to really think now on how we should be doing risk-based STI screening for point-of-care tests. We cannot screen everyone also. We need to be strategic when we do the screening strategies that we have. And of course, in women and men in the community, we still need to do our health education and counseling and promote our condoms. Of course, as you know, there's a study in Rwanda. I wanted to post you that this study was done in Rwanda, wherein they did a point-of-care test, meaning it's not a real point-of-care test. This is Gene Expert, and you will note that with this, it could really improve the diagnostic performance of screening, for the sensitivity and specificity for these different STIs compared to having a syndromic approach. But the issue is really the cost of all these point-of-care tests. And what we have in the landscape now, there are more and more different diagnostic and molecular assays that are being developed. Before we have these big Gene Expert machines, now we have smaller machines that can be used. But the biggest barrier for most of these tests is really, it's still not a real point-of-care test. It's not cheap. You can use it in the primary healthcare level. It's probably at the secondary level of care. So what is the opportunity for us in terms of this point-of-care test? If you look at the current landscape for antimicrobial resistance in gonorrhea, we do have a plan. We look at here, if you look at this part, we are now looking at a point-of-care test for gonorrhea and chlamydia that could probably be almost like available at the primary level of care. And if we can limit the cost to less than $3, I think this is an opportunity for us in the AMR world to really support some of the issues in the development of our point-of-care test. In addition, with this AMR initiative that we have, I think it's still very important to look at new gonorrhea treatment, but I think I urge most of you in the African countries to also look at how you should be setting up your gonorrhea surveillance system. Imagine if you have a no gonorrhea surveillance system and you are procuring STI drugs that will cost you millions, while you can invest on a good AMR surveillance system that will cost you $100,000, I think it will save you much more money to do that. One of the things that we have also been doing is really facilitating a gonorrhea vaccine. So we are now in the stage of looking at, in New Zealand, for example, there was this meningococcal vaccine that was effective for reducing transmission to about 35%. It's really not that good, but at least there's something that's on the pipeline in terms of gonorrhea vaccine. One of the things that we have also been imploring, and I think this is always an opportunity for us, is really the mother-to-child transmission of syphilis. We do now have even a rapid dual HIV syphilis test, which would increase the coverage of syphilis screening among our antenatal women. And another initiative for us that is really interlinked with our STI program is really the elimination of cervical cancer. Remember that HPV is an STI, and HPV causes cervical cancer. And that with women, they need to be vaccinated, and HPV, and about 70% of women should have at least an HPV screening, and those with cervical cancer need to be treated. Again, we did a systematic review among patients who are doing PrEP. And if you look at this data, the prevalence of STIs among PrEP users are quite high. See, in this data, we see a chlamydial infection of 10 and gonorrhea infection of 11%. And the incidence rate for these people who are on PrEP, you will note that for chlamydial infections, about 21.5%, and gonococcal infection is about 37.1%. Well, you might argue that you have been doing and wrapping up your screening, so this is probably why you are also increasing the rates of incidence for chlamydial and gonococcal infection with PrEP users. But this is good because then you're able to treat them. But this is another prevalence and incidence among African women using PrEP. If you look at it, in all these different trials that are being done in Africa, you know that STIs and chlamydia infections are quite high. So there is really an opportunity for us to integrate PrEP and STI services, where this is an area where we can optimize STI services in terms of STI diagnosis, community-based services, partner notification, and condom and lubricant promotion. Again, another study that has just recently been developed is the ECHO trial. And if you look at this ECHO trial, look at all the rates of family planning users, and you have high STI rates even among family planning users. So in high prevalence setting, I think there's still a role for some of these family planning clinics to be providing and integrating STI services. So what can we do now? First, we need to invest in STI care. Symptomatic patients are still very important to tackle. We need to make sure that what tests we have, we probably need to make sure that we decrease the cost. Or we need to develop more cost-effective point-of-care tests. Integrate STI services in our PrEP and also in family planning and adolescent services, especially in high STI prevalence setting. What we haven't discussed really is our expedited partner management. I think when you have an STI, I think it's very important to have that partner be treated. Address our antimicrobial resistance, scale up our HPV vaccination, and we need to have a better way to promote condoms in a smarter way. So I think those are things that we could really do, and it can really go a long way. STI can control, can have all these different effects in our life. So thank you very much.
Thanks, Theodora. And what we thought we'd do is just take one or two key questions, and the rest we'll leave to the discussion at the end of the program. Are there any questions? Thank you very much for that excellent talk on the stats and the challenges in screening and testing of STIs. There's a question there at the back. Gina?
All right, thank you very much for the nice presentation. I'm Washington from Malawi. Having seen the data that STIs are increasing, and most of the countries in Africa, we are still using syndromic malignant approach. When are we anticipating to have this point of care tests? Because now looks like time is running out, and the control of STIs is not as good as what we wish to be. Thank you.
Thank you very much. Do you want to, shall I answer that, or do you want the other questions? Yeah, I think this is something that all of us are really working on at the moment. How to make a real point of care test. WHO is trying to facilitate the development, but we need donors. We need people or funders that would help us to facilitate and move forward with our point of care test initiatives. Of course, we do have one that is already on the pipeline. We hope to have it because of this antimicrobial resistance in gonorrhea. It's also very urgent that we have this point of care test so that we can conserve the current drugs that we have. And so hopefully, if things get to be okay, 3-4 years, that would be good. But I also urge manufacturers. I mean, we've done to some of the manufacturers, and of course, they don't want to invest in low and middle income countries. They want to do it in high income countries where they, of course, need to profit from this development. So we hope to have it, but it will take a bit of a time.
I think we'll take that one last question at the back.
Okay, thank you for the presentations. As you mentioned, there is evidences that STIs is increasing in PrEP users. And you advocate for an integration of STI and HIV services. So, what concretely do you propose in terms of key messages in order to go with the two of them that can sometimes be contradictory with regard to condom use?
I mean, I don't think there's any contradictory when it comes to condom use. Everywhere for STI and PrEP integration, I think any key population, if they are with PrEP, they need to be screened for STIs, right? I think that's a big integration process. And while and those with an STI should be offered PrEP. So that's a good integration. It will need minimal investment to do that. And as you're moving with PrEP and you're understanding that STI is becoming a problem, then communication with condom use is still very important. I think Vidya is going to give more of enlightenment in terms of condom use.
Thanks very much, Theodora. Can we give her a round of applause? Thank you. We're going to move on to another WHO presenter, Leopold Uduraga-Ogo. Sorry. He's focused on SRH and STI prevention work. He's a medical officer based at the WHO African Regional Office.
Okay, thank you, Madam Chair. I think this presentation is just a follow-up of a previous one. Is about a global strategy on STIs, prevention and control, and how in Africa we are taking forward this global strategy for prevention and control of STIs. Okay, we'll go quickly through the background, framing of strategy, the vision, the goal, and the target of the strategy, and more importantly, the strategy orientation and the priority interventions. Just as a background to say that we have seen the high burden of STIs worldwide, and in particular in the African region, and to address this issue at global level, we have been developed, in fact, 3 global strategies against for ending AIDS, STIs, and viral hepatitis. These 3 global strategies are linked because we all know that we are sharing HIV, STIs, and viral hepatitis are sharing almost the same epidemiology, the same way of prevention and control. So these global strategies 3 are linked. And at regional level, we have taken this forward and developed a particular framework for prevention and control of STIs. And what's important is that the strategy about the framing draws on 3 overarching framework. The first framework is about the universal health coverage. This is very important. The second one, the continuum of services related to STIs. And the last one, the public health approach. With regard to the universal health coverage, this is very important, and the aim is really to make sure that all people receive the services they need at sufficient quality to make a difference without incurring financial hardship. This is very important, and it is mainly about increasing the population, the coverage of the population, through decentralization of the services, of course increasing also the range of services that should be offered to the population, and reducing the direct cost supported by the population, so that the financial barriers are completely removed. So this is about the universal health coverage. The continuum of services is about making sure that the continuum spans the full range of required interventions. Not only the prevention, but also the diagnostic, the treatment, and the care that is needed to achieve the strategic targets and includes all people. So it should be a continuum of services to address. And the public health approach is also something that is very important in this framework, is about making sure that the prevention, the promotion, and the quality of life are taken care of. And for this to happen in countries, we need standardized, simplified protocols and guidance. We need decentralized service delivery. It's very important to reach people where they are, including communities. It's about also the focus on equity. And the community participation is very important. And of course, making sure that the services are provided free of charge, or at least they are affordable. Okay, what is important also to note is that the framework has three focus areas. The priority areas is, of course, first the gonorrhea, because of the risk of resistance and untreatable gonorrhea. Teodora just talked about this. It's very important that we focus on this. The syphilis is the second area of focus also, because we know that we can reach quickly the elimination of congenital syphilis, including if we take care of the screening and treatment of syphilis in pregnancy. And the third one is about the HPV, human papillomavirus, and we know that the vaccination exists, and to talk about this, we need to increase the coverage of vaccination. The vision and goals, the vision of framework is really to make sure that we have zero new STI infection, zero STI related death, and zero complication, discrimination in a world that everybody has free and easy access to prevention and treatment services for STIs. And the goal, of course, is to end STIs epidemics as a major public health concern. For this, we have some targets. I don't need to go through all of them, but you really need to reduce trichomonas pallidum incidence by 90%, Neisseria gonorrhea the same, by 90%. By 2030, this impact targets are by 2030, less than 50 cases of congenital syphilis per 100,000 live births in 80% of countries, and of course the coverage of HPV should be at least 80% in minimum of 80% of countries. And the milestones, of course, the milestones are also there. Here report with the increase of pregnant women screened for HIV and syphilis, about the HPV vaccination, and also about access to full range of services, in particular for the key population. The priority interventions for which we have are organized along the universal health coverage, and also we have information for focused action. We need data. Data are very important for rational decisions. We have intervention for impact, with education, HPV vaccine, condom, adherence and treatment, partner treatment, EMTCT, HPV vaccination, and control of gonococcal antimicrobial resistance. We have delivery for equities. We have a huge range of intervention there. Integration of services, the key population, community involvement, and the quality of care. And we have the financing. Also, we have some intervention targeting the financing, making sure we have an investment case, financial protection, and of course, the procurement system needs to be improved. And lastly, we have the innovation. We already talked about this. You need to think about innovative approaches, including the vaccines and the point of care test. And all things should be rooted under the national leadership, partnership, accountability, and of course, the robust monitoring and evaluation system. What to say is that it's important to know that if we really reach a universal coverage in STI response, we'll be able to reach all these benefits, including combating antimicrobial resistance, eliminating adverse neonatal outcomes, in particular due to syphilis in pregnancy, reducing HIV transmission, of course, because when STIs are favoring HIV transmission, preventing cancer. I've seen that almost 500,000 cases are happening every year, decreasing burden of infertility. We talked about this, particularly due to chlamydia and gonorrhea, and of course supporting health for population, in particular the young people who should benefit from a more sexual life. And of course, all this will contribute to accelerate SDG action. So just to say that this framework is an ambitious one, it's aligned with the ATG, requiring political and adequate resources. And what is good is that this regional framework has been adopted by the regional committee meeting in August 2017, and this regional committee involved all the ministers of health in the African region. So this shows an ownership and a good commitment to implement this strategy. And thank you for your attention.
Thank you very much, Leopold, for sharing the framework with us. I think to keep to time, we'll just take one burning question, if there is one. Someone? There's one question at the back. Anyone else? Okay.
Okay, thank you. Among the tools you went through, there is vaccination for HPV. I want to know, in some contexts like myself in Burkina Faso, we actually found other genotypes but are not covered by the vaccines available now. How can WHO advocate for countries like us to have efficient vaccines? Thank you.
I'm very grateful to be here and thank you for the presentation. I just would like some guidance on, we heavily speak about integration and it can be misinterpreted. And STI is one of the program or maybe the intervention that suffer when it's integrated and less resourced. In terms of M&E, to ensure that STI screening, treatment and prevention is integrated, is there any document in the WHO that can guide countries on how to ensure it's integrated through those primary healthcare services, maternal health, family planning and VMMC and you name it? How do we ensure it's integrated within HIV programming and so forth? Because it just becomes so hard that to integrate, but we have no data on syphilis, chlamydia, you name it.
Okay, thank you for the question from Burkina. What is true is that the vaccine covers most of serotypes that are known in countries, but also what is good to notice is that I think Aurora talked about this. We are thinking of innovation, and there's still research. We continue to. The research activities are continuing. We're thinking about innovation so that we make sure that we cover most of the serotypes in various countries. But for the moment, the vaccine that exists is really covering, I think, most of the serotypes that exist in the various countries. With regard to the integration I think is a very important aspect. If we want really to reach most of people in need, we need to integrate the services. The question is how, and this is still the question under discussion: how to integrate, how to do best, how to better integrate our services. We can still discuss this maybe after the presentation, but this is something that we need to continue discussing, making sure that when we receive a client, an adolescent or an adult, we make sure that we take into consideration all the aspects of this person. Not only taking care of the pregnancy, but during the pregnancy we can check and see if there is not any IST, any sexually transmitted infections, and on other diseases. And of course we can address this at the same time. The most important thing is this. And of course the tools for monitoring, evaluation, we should still think about this, how we consider all this data in our reporting system.
Yeah, I think for integration, there's a WHO IPPF framework, and there's this UNFPA, UNICEF, WHO IPPF framework. It's a high-level framework for integration. But what we are really missing is really doing it in the ground. Just do it. And I think this is where we learn experiences, because we've been talking about it in high level. We need just to go down and say, let's do it, and let's see how we can do it in a more practical way.
I'm sorry, I know there's other questions, but I think we'll need to leave them for the discussion, otherwise we'll get behind. Our next speaker is Catherine Ngugi from Kenya, and she's the head of the National AIDS and STI Control Program there. And she's going to give us some insights from being an STI program manager. And when I asked for someone to give me a bit more description, they said, she's an STI champion. So welcome, Catherine. We look forward to it.
My presentation will be on sharing the experience that we have in Kenya. And not only in Kenya, I'll share as well what we are doing in East African community. And I hope most of you know the countries in that. So that's how, Kenya, I think we just did our census, and that's our population profile, and showing that the prevalence of, I'll bring something about HIV, because I think we need to remember that HIV is still an STI. So we had 47 million, and male and female are both 1 to 1, almost 1 to 1.3. Oops. So still, and I think all of us, the three presenters before me have highlighted, there is still a major public health problem. And we have the non-curables and the curable ones. The prevalence of HPV in the country is 5.8, and the HCV 0.5 to 2.0. Now, at least for hepatitis B, it was included in our CANFIA, which we just concluded to release the preliminary report very soon. Now, we have few studies, and I think most of us can agree, especially in sub-Saharan Africa, that we don't have really the data of STIs in the countries. So even what I will highlight is some of the few sites, the studies that have some of the data. Before, we used to have functional clinical STI clinics, but with the time they have died, and the ones which are functioning are very few. We have few studies which I'll highlight, which have GC and CT, especially in our PrEP sites. And the most shocking part is like the girls, adolescents and girls and young women who are between the ages of 16 to 25 who are coming to correct PrEP. In one site, they are being screened for gonorrhea and chlamydia. Unfortunately, the prevalence there is almost 23%. And to give it to to absolute numbers, is almost like 89 in 488 clients. And remember, it's prior for them being given the PrEP. Where have we come from? Now, when it comes to hepatitis B and C, most of our data comes from our National Blood Transfusion Service. We don't really do as a routine, even in our DHIS. And the other area that we can get our data is from mostly our ANC clinics. And you see now this is a specific population alone. Now power study, you can see this one is the one that young women between the ages of 16 to 25, and you can see the prevalence of 18% of chlamydia and gonorrhea. And then the others are just piecemeal studies here and there, but not really representing the country. Okay, sorry. These are the reported cases. One of the challenges we have in Kenya is we have STI reported, but it's not granulated. It's not in syndromic, it's just reported in an STI. So if you want to know how many are urethral discharges, vaginal discharges, ulcers, you can't granulate to that. And you see we have to start all the way from our tools. And most of the countries, we have that. And I think I'll give some good news that we are doing in the country, in the EAC, which we are already in the phase 2. Now in syphilis coverage, and I think this has been highlighted in several sessions before, we have syphilis testing coverage. Because of the dual syphilis, the government of Kenya realized that we have a gap in this. We bought our kits, and you can see how we moved from 54% to 71%. Now I think it's almost 85%, because this is it's 2018. And this is a dual, and you can see how we were doing in terms of the ANC clients tested for syphilis and the ones who tested positive, the negative ones. As a program, the government is leading into it. How do you choose this? Sorry. Yeah. We have at least STI and viral hepatitis is a priority right now in Kenya, and we have established a TWG since 2018. We have now a Save the Duo testing kits that's free. We have now available. We have STI and viral hepatitis guidelines separate, and have mentioned about we have conducting 2 surveys. Now let me mention about the EAC Boresha Huduma study. Now EAC Boresha Huduma study is done within 6 countries, and Rwanda is one of them. Kenya, Uganda, Tanzania, mainland, and still Zanzibar, Burundi, and South Sudan. Now this study has 6 objectives. One of them is to document STI prevalence, both in syndromic and causative. The second one is to document policies, strategies, and guidelines. The other one is to document STI management practices within the partner states. Then establish AMR for the GC. Then determine phenotypic and characteristic molecular characteristics and identify key areas of harmonization. We have already done the phase 1, and now we are in phase 2 of doing the phenotypic and molecular characteristics. To move first, this is for the clinics which are already functioning, and for the ANC mothers who are already accessing especially the dual kit. And you can see the stories that they are really appreciating what is already being done in the clinic. They are appreciating it. Where do we want to go? We know we need definitely country ownership and integration of health within health systems and strategies, which we are doing. We need effective partnerships and a public health approach and intersectoral collaboration. And as one of the big 4 agendas in our country is to have that UHC, is to put it, embed it within our overarching framework within the country. And so we hope that we can be able to do the viral hepatitis and viral hepatitis transmission, especially the eliminating the HCV as a public health thing. What are the challenges? We have weak integration of STI and viral hepatitis in other programs. We have incomplete policy documents, especially guidelines, strategic plan, and training curriculum. We have lack of awareness of our healthcare workers, especially on STIs. We have expensive diagnostic and treatment commodities. And thank you, at least we have an initiative to ensure that we can have a POC for some of the STIs. And then we have inadequate capacity building, training, support supervision, and mentorship. And the surveillance system is one of the areas that we really hope to establish surveillance system within the country. And we know we have insufficient funding and a willingness of the current funders, especially within HIV, to integrate STI and viral hepatitis. What are the way forward is to enhance at least data demand and information use, strengthen commodity supply, and have training, continuous mentorship, and the areas of promote strategies to enhance STI prevention, ensure that it's integrated like within the health system, especially Ramanka, and have leadership from the top all the way to the ground. And issues to do like the development of new technologies. And like we did, I think less than 3 weeks ago, we just launched currently HPV vaccination among our young girls. And I wish to acknowledge our Minister of Health, NASCOP, and Global Fund, which is really supporting us in this. And we hope that at the end of it, we'll get there.
Thank you very much. That was a very interesting presentation. Are there any questions for Catherine? There's one there.
Thank you. I would like to inquire from Catherine. Talking about launching of HPV vaccination among the young girls.
Yes.
Does this mean that the HPV vaccination doesn't work for adults? And if it works, there are some populations that are at high risk of getting HPV, like sex workers. Why don't you include them among the populations to be vaccinated? Thank you.
presentation. I have a concern more than a question, and it comes from a real story. But now that we're all thinking this is what we're doing, we're integrating SRH into HIV properly, and obviously STI is part of that. And I just want to say, are we looking at the way that we're doing this do we know who is the person providing the integrated care? Are we making sure that it doesn't put vulnerable young women at more risk of being seen by people who may commit further STBV style treatment, basically abuse, yeah? So how are we making sure that we, as healthcare workers or the healthier systems, are ensuring that we have the right people delivering the right service?
Thank you for your two questions. I think it was, to us, it's a start, at least for the young girls, hoping that when we see how we do with the 10 to 19, then we can be able to scale up to the others. And we recognize that not only the young girls need it, even adults and other populations that require it. To us, at least, it's a starting point, and we will get there. So your question, Lita mentioned that within the East African community, we realized we have a problem with STIs. Not that we're already doing it, and we are doing a study right now with support of CEDA and within the East African communities, whereby the countries, the expertise, and even the IPIs are coming from the country. Know that you're already doing it. And if you have heard the 6 objectives that I have listed, that is what we're going to find out from the countries. Where are we? And document all these practices, document the prevalence. And then from there, then we can be able to harmonize and know where do we go forward. So we don't have the data yet. Before we just start the first phase of the programmatic collecting the data, then we go to the laboratory phase next. Then we can be able to answer some of the questions, especially like to GC. But I think East African community is way ahead. Thank you.
Thanks very much for that. I know there's many more questions, but please save them to the end. So I'm going to hand over to my co-chair now.
Thank you, Meg. So now I'm going to invite Natasha Mwasa, who is a champion for sexual reproductive health and rights for the Global Health Leadership, to give us some insight from a young adolescent women related to STI. Natasha, you have 5 minutes. Thank you.
Thank you so much for the time notice. Good morning, everyone. Good morning, everyone. Great. So like he's mentioned, my name is Natasha Mwansa, and I am standing here going to take the role of a social accountability monitor, and I'm going to start by telling you all a story. So as a social accountability monitor, what I do is I work in a community, and we go there every Thursday, and I go and speak to various young people. And sometimes we have outreaches, and so we just reach out to these young people about information and services that they can access at this particular youth-friendly corner. And so this one time we find this young man, he was looking really sick, he wasn't doing so well. And so I decided, let's target him, let's ask him what's going on. And we began to have a conversation about all sorts of things related to sexuality, and we talked to him about STIs and everything. And we noticed that when he heard STIs, he was stunned. And so we thought of dwelling on this topic a bit more. Little did we know that he was actually experiencing some of the symptoms that we were mentioning. And to him, it was normal. His friends told him it was normal. We are all going through the same, so it's not something to worry about. And that worried us a lot. And so we told him, you know, there's a youth-friendly corner right by the corner in this community where you stand, and you could visit them, and you could visit the clinic too, because they have services that you need. And so he decides to do that, but then unfortunately, it was a bit too late. 2 weeks into him visiting the clinic, he passed away. That was really sad for us because we then thought if we had maybe gone earlier, if this and that, but then it happened and we didn't have control over the situation. But then one thing that really amazed me is after we told him about the STIs and everything that he was going through, he told his friends about it. And before we knew it, at the end of that month, some of his friends joined the youth-friendly corner. And they told us, no, one of our friends, though he passed away, and we said, wait, is it Mr. This? And they said, yes. And we said, this is a success story. Because we don't really realize just how important it is that young people have conversations around this and actually have the information they need so they can affect their peers. She was, when the doctor here was talking and she was looking for champions, I thought to myself, young people can be your champions, We're the best people to actually stand because the burden of STIs lies on young people largely. But we don't just want to be a face on a photo. We want to be meaningfully involved throughout the whole process. Because no one can tell you what we're going through better than we can. And no one can give you those solutions better than we can. So, you can give me a round of applause. That was powerful. So, most STIs are actually silent. And when I talk about silent, I don't mean silent in the sense of the symptoms are not easy to read. I think some of them are really easy to tell. You can tell some of the symptoms. But then when I talk about silent around young people, it's many people are not coming out about these STIs. They're not talking about them, they're not talking about what they're experiencing, and hence the silence around them. And that's really sad. And this also means that even if they are silent and some of the symptoms are not very easy to tell, that means, of course, we've gone through the presentations, there's need for screening, there's need for programming, there's need for treatment to be put in place, but then this is not very possible, especially, not that it's not possible, rather, this is not happening right now, especially in African countries, because firstly, one, the innovation around all these issues is not as developed as we need it to be. And then secondly, there is so much stigma around this topic that even bringing it out to a healthcare worker is an issue. Imagine a 16-year-old girl who's just had a first sexual intercourse or sexual relation and she's confused. Maybe it's not even her fault. Maybe she was perhaps forced into it or something, but then she's confused about it and she goes to a clinic and all that she's getting is bad attitude from a nurse who's not even trying to understand what she's gone through. How do you then expect her to even want to access these services? And not only that, even if you do go to some of these health facilities, let's just be honest, you won't really find them readily available or actually even there to give it to you. One of the reasons why this man actually passed away was when we spoke to some of his friends, they explained to us how he would go back and complain and say, I stood in a queue today and when it was time for them to service me and everything like that, they prioritized the older people before they came to me. So then what are you trying to say? Are you trying to say that just because we're young, these services are not supposed to be given to us because we are not allowed to actually experience some of these STIs? Even if that were the case, the sad thing is it's happening. And we shouldn't look at us as young. Look at us as human, who actually deserve access to these services too. And also, it's just a matter of conversation, really. Sometimes one simple conversation can lead to whatever we actually want to build on. So what exactly do we need to do to actually address some of these barriers? Firstly, let's increase awareness around STIs. Like I told you, I'm a social accountability monitor and I work with young people on the ground in different communities very often. And so just this week on Tuesday, I was back home and we were commemorating World AIDS Day. And so we had an outreach and we were talking to so many young people. And I go to some of them and I tell them, do you know what HIV and AIDS is? And they say yes. And I ask them, how is it transmitted? And they say by having sex. And I say, okay, good. Do you know what other STIs exist? And they look at me and say, what are STIs? And I'm looking at them, I'm like, you don't know what sexually transmitted infections are, rather? And they say, no, we don't. And we had to sit down, we had to organize a bunch of young people and explain to them that it's not just HIV. So if we could have young people who actually know what HIV is but don't know what other STIs are, that means that there are many other young people out there who might be experiencing it, but then for them it's only one disease that exists that can be transmitted by having sex, and that's HIV. So what are we doing to actually raise awareness on the issue? Because it's not just one disease. There are so many other things that they could be affected by, and they need to learn about this. So just ask your neighbor, what are you doing about it? You have to do something about it. Also, if once young people actually realize just how important it is to actually have, once they understand what STIs are and how important it is to access services and where to go concerning STIs, then there will be an increased demand, because you will not demand for something you do not know. And with increased demand will come increased supply. But then it's not always the case. We are here and we are talking and we have government heads and we're telling them we need action, we need that. But then how often do we actually go back and follow up on these issues? That's why social accountability is key. It's not enough to just talk to stakeholders and tell them what we want and tell them to increase budgetary allocations, tell them we need innovation, but let's go back and keep putting pressure on them, because let's just be honest. Most of the times, every decision that we want to actually see happen depends on the people that we have put in power. But that doesn't mean we shouldn't forget our power to make them do what we want them to do. So let's make sure we don't forget what exactly social accountability can actually do for us. And then also, let's not forget how powerful the media is, because sometimes I think we do understand how powerful it is, but we just don't see them as a partner as much as we should. The media is actually quite influential, and most of the time, when we look at the media and the messages they portray, they actually shape the minds of young people. So if the media could actually portray the messages and they could actually show us and engage in us and explain to us what these STIs are as young people in an engaging and actually attractive manner, then we'll actually see change. And then I'm just going to now go to my last point. Like I mentioned earlier on, in as much as we want to meaningfully invest in young people, let's not forget to meaningfully include them throughout the whole process. Because we're not just going to be beneficiaries anymore. No young person is ready to be that. But then that doesn't mean that our capacity to do this shouldn't be built. We want champions, but then are you willing to actually invest to build their capacity to be champions, to involve them throughout the whole process, and so that they can be part of this story? There is no other better person that can actually be involved than the persons who are most affected by this. So let's not forget just how important it is to have young people involved in the fight against and on reducing sexually transmitted infections. And just lastly, we have so many people here at ICASA and we are all trying to be a voice, and it's very important and engaging, and I thank the organizers for actually having me here. But then let's not forget that we have work to do back home. So many people are actually suffering. So many young people need to learn about this and need to know about this. So let's go back, look at the young people we have, involve them, listen to them, because they have solutions that we're all trying to figure out in this room. So let's not forget, young people should be put first, but they should be involved throughout the whole process. And then we're actually going to come back next year at ICASA and have success stories on how STIs are reduced around Africa because of what young people have done. Thank you.
I think we have to agree. This was very powerful. She's really a champion. Please, we have to engage young people. We have to engage the media. We have to ensure the social accountability. Thank you so much, Natasha, for such wonderful sharing. Let me now invite Professor Malia Laga, who works with the Institute of Tropical Medicine in Antwerp, to talk to us about screening of STIs in MSM in South Africa. Prof. Malia, you have 10 minutes. Please, you're welcome.
Okay, so I'm going to try to share some experience with STI screening in Africa, not in South Africa, actually in West Africa. So that's next. I'm pointing. The middle. Okay, sorry. Okay, so I want to say I give this talk, in fact, on behalf of my colleague Bea Velsteke and Edith de Batsere, who have actually been the driving forces in the collaboration of this project. Because it's a project involving many partners. Okay, needless to say, prompt treatment of STIs has both individual advantages as well as community and public health advantages. Okay. Maybe just to recall, I'm one of the people who have been working I started my career working on HIV in the 80s, but then the focus was very much on STI, and we were discovering that STIs were enhancing transmission of HIV, so there was a lot of activities happening in the late 80s and the 90s on STI, and then with for many reasons, attention has shifted quite a bit. But at least I want to go back. So approach to a symptomatic STI is when there's no test available. From the old days, it was already thought we could do syndromic approach, meaning we can immediately, based on some symptoms, treat people according to the epidemiologic evidence we have, the concurrent infections that happen. And here you see an example of a flowchart, a syndromic approach example from the WHO guidelines of the late 80s. So there was the advantages are, of course, no need for further tests, prompt treatment, stop further spread, simple, easy, and cheap. And I think there still holds today for some of the syndromes. I think there's a bit of an overreaction now against syndromic approach, like this is crap and this doesn't work. I think the issues are very much when it comes to women and STI, but this talk will is going to focus on men. And so when it comes to syndromic approach for urethritis in men, we could still say that this is still a valid approach, as was a review that was written by Theodora some time ago, what the conclusion was, for urethral discharge in men, the sensitivity and specificity are still good. But that's for men who presented symptoms. The issue is, of course, when you have no symptoms, how do you get to know when people have an STI? And then that's when we need a test. I mean, the test, I'm sorry, but this technology is really becoming tired. No, but okay. So, well, that has been said. The gold standard now for diagnosis of gonorrhea and chlamydia or nucleic acid amplification tests. They are one of the main reasons is they are expensive. Yes. So we are dealing with antimicrobial resistance, which is one of the reasons why we don't want to over-treat, just not to make it worse. Yes, next. And so when it comes to STI in men, and specifically men having sex with men, then we are dealing with, or we are confronted, I would say, with two issues that have become clear from other studies. Before I will share some of the experience of the survey. And a study among MSM in Nigeria, Lagos, which was presented at the conference in Amsterdam last year, showed, in fact, the enormous rate of STIs that were asymptomatic. So, in fact, they showed data from Lagos, gonorrhea prevalence 28%, chlamydia 18%, syphilis 19%, and all infections asymptomatic. On the other side of the slide, you see a survey among MSM in South Africa. Where you can oh, no, I didn't do anything. Where you can really see the importance of the extragenital infections. So you see, not only do we find the infections in urethral, so in urine or in the urethral site, but also anal and pharyngeal sites. Like anal is the blue bars, you see, both symptomatic and asymptomatic infections, but also pharyngeal infections and a combination of all. So two things that become important. Yes, next. So now I'm going to share some results on a STI screening that was done in a study called Co-MSM. It's a study in 4 West African countries. I'll show you the sites. With 2 European partners supporting some of the efforts, ERD France and then IGM in Antwerp. And our support is on one of the supports is on STI screening and the technologies. Yes. So when we, just a little background, because this is, in fact, we are learning a lot. This is new data. HIV prevalence among MSM in Africa is high. I mean, you all know that. There's been many studies and surveys now presented. It's much higher than the general population. Incidence, the few incidence numbers that we have are high. There's poor knowledge about HIV and HIV prevention in many of the MSM communities in Africa, and homophobia and sexual violence are high. When it comes to, yes? And so that's the study I'm actually presenting. It's done at 4 sites in Togo, Burkina Faso, Mali, and Cote d'Ivoire, each time in the capital city. Yes, next. And the idea was, because there is still no point of care test, in order to have some idea of STI, there was gene experts put in place in 4 central laboratories in the 4 cities. So it's, you can see some of the, and the idea, the results were ready within at least less than 72 hours. Yeah. Okay. Another idea was also there would be samples taken from the 3 sites: urine, anal, and pharyngeal. They would be tested, and they would be pooled in one sample. So in order to save cost, they would be pooled. When they're negative, they're considered as negative. When positive, they would be unpooled to see where the positivity was. Yes. That's just a picture of, there was a lot of, I mean, it must be said, gene expert is not a simple test. It's not a point of care test, so it requires some training. This is an example here of some of the, one of the teams. I apologize, I don't know which one it is, but maybe people in the room will recognize who are here. Okay, yes, next. So just some results now, because I think it's important to share some results. Here you see the results for chlamydia trachomatis. Prevalence of chlamydia trachomatis in any of the sites is the yellow, in urine is the red, and in blue is anal, and in that undetermined color is pharyngeal. But anyway, you just follow the order. And then you'll see that you see the prevalence is relatively high. Interestingly to note that none of the chlamydia strains were LGV strains, something we are seeing emerging in many European countries as a new epidemic. LGV chlamydia strains in among men having sex with men as an epidemic, really. It's still, yeah. So I can push once more. Okay, you have it all. But gonorrhea, maybe the most important one in terms of, you see prevalence is relatively high in the 3 countries. When it's in any site, it varies between 5 and 12%, 20% Burkina Faso, 16%. You see also that the extragenital, so the anal and the pharyngeal, the anal is the highest one. That can be expected. Let's say, but also the combination with pharyngeal. Okay, interesting also was that there was only 1 case of syphilis detected and 1 case of trichomonas. It's been known for a long time that syphilis has been much lower in West Africa than in Eastern and Southern Africa, but we were still surprised. If you compare that with rates of syphilis in European, I would say, cohorts of men having sex with men, you find much, much higher rates now. Yes, next. Okay. Also to say, and that's interesting maybe, that it's not only the baseline STI rates that's combined for the 3 sites were high, but also the incidence rates are high. At 6 months and 12 months you could see reinfection rate. These are people, only the people who were treated and negative again were, yes, next. Once more. And so again, it's not only the at baseline that STIs were asymptomatic, because you could think, yeah, that's people who have been accumulating and those who symptomatic were treated already, but also the new infections, the majority were asymptomatic. So in terms of strategies, this is important. Yes, next. Maybe just to, yeah, next, you can push once more. Yes. just to say that the validity of pooled samples versus the individual was very good. So I think it's also a lesson to learn that, at least while we waiting for the simpler and cheaper point of care tests. I mean, if you can set up GeneXpert and then you can actually use a pool test to save costs, that is something that is a useful lesson. Yes? Keep going. So conclusions: high burden of STI among MSM in West Africa, many extragenital infections, most of the infections asymptomatic. Screening of STI with GeneXpert is feasible, but the importance of training and supervision and quality control. It is not a simple test. It requires laboratories with people who are well trained. Pooled samples performs well and is cost effective, so that's at least a way out for reducing cost. Yes? Next. And now just a few remaining questions. That's my last slide. Yes? Word first? No. Yeah, okay. I think an ultimate thing is this question, the screening for asymptomatic infections. I put it a bit provocative, is it needed? Because that's a discussion for the moment in Europe. What is the relevance of asymptomatic STI especially in men? Here we're talking about men. They don't have the complications in terms of fertility. They don't have so is this really, except maybe to address the epidemic and public health reasons? There are questions. I don't have the answer. There are now people who propose in Europe to not screen so often anymore because you indeed induce more antimicrobial resistance, and in fact, many of these infections remain asymptomatic. We don't know the natural history completely of asymptomatic infections, especially extragenital infections. So that's definitely a topic that will remain on the agenda in the next years in terms of frequency, in terms of reports. Next. So then what to do when there's no point of care test available, when there's no technology available, and maybe next is combined answer. Where are we, and can we think about selective testing and treatments if we have no point of care testing available? It's very difficult for the moment to have any idea who is at higher risk of having an STI. But strategies of selective testing based on some epidemiologic criteria, some risk criteria, this needs further work, and there is already some work ongoing on that. But that's definitely a way to go, to not have to screen and invest for everybody, to reduce cost. Yes, next. I think it's very important to think about role of partner treatment. And if you think about MSM in Africa, it may be somewhat different. And for instance, the experience we also have with MSM in Europe is that many of the MSM, one sentence, many of the MSM in Africa, and at first qualitative research, still have sex with women. Or so the connection, as in terms of with the female population, is important enough to keep the epidemic and the implications for women. So again, that has to be further defined. And to just summarize, and that's my transition to the next person, I think we have to invent and have a new narrative. Make condoms cool again and great again, but we have to have a better narrative in the whole new world of antiretroviral-based prevention, where condoms have kind of slipped off the table, both in the HIV world, STI world, and also the family planning world. So anyway, but Bidya is the best person to address this topic. So thank you very much. So I want to say that because then you see, thanks to these are the names of the collaborators from the 4 sites, and at least my gratitude, because I'm just in fact reporting some of the results of the hard work of the people on the slide here.
Thank you, Maria. That was really very inspiring. So, any burning question? I can see one hand there. Can you take the increment?
Thank you very much for your presentation. My name is Blessmi Ajani from Nigeria, and I think it's very important that we're having this STI discussion at this time, while we are only focusing on HIV. So my question is, I would like to know it will be interesting to know what might be responsible, or maybe factors responsible for the low prevalence of syphilis. I feel there might be something to learn there and adapt towards the other STIs that are very high in West Africa.
Thank you. Maria?
I really don't know. Honestly, I was very surprised when I see this. I know it has been, when you look at prevalence rates of syphilis, for instance, among pregnant women in the different sides of Africa, you always see consistently much lower rates in West Africa, below 1%. But maybe there's people who know it in the room here. Think about that.
So because of time, I'm not allowing the second question. Let us now move to another presentation. Now I want to invite Bidia Depathis, who is the Global HIV Prevention Advisor from UNFPA, to talk to us about condoms as the heart of STI and HIV prevention. Bidia, you have 10 minutes.
Yes. Okay, say sex. Sex. Okay, 100% of the STIs are sex. We agree? Okay, did you talk about integration? I mean, you have it. It's here. We want integration of services, STIs, HIV, family planning, etc. This is it, the only multi-purpose device. So instead of dreaming, waiting for the vaccine to come, etc., use a condom, okay? How do I do this? As I said, you want to talk about STIs, I cannot be vertical, I can't. So although it is an STI session, it will be HIV, it will be family planning. So STIs, HIV, family and intended pregnancy, use a condom, right? MNF, male and female condoms. So, I'm going to be like Mary, I believe. So, condom for HIV, I believe I would need your help as well. Now, play with this. Just look at me and play. Play. So, should we still have condom for HIV? We know it's good. Okay, we know we have all of this amazing innovation when it comes to HIV. It's excellent. But what we also know that is for millions of people, we still need condoms. We only have about 400,000 people on PrEP. We're gonna get there, but we're not there yet. So we need condoms. I'm not gonna talk about PrEP or MSM, etc., because it's already been taught about already. So we also talk about people already living with HIV, taking their drugs. Excellent. But we also know that 35% of the people living with HIV don't have access to their treatment. We also know that for HIV not to be transmitted through sex, we still have to have virus suppression. We don't have it. 53%, meaning the majority, still have not expressed that. So they need condoms. Next. Okay, contraceptives, please go. I'm going to be fast. We have over 200 million women wanting a method to prevent that pregnancy they don't want. They don't want it. Do you get it? And condom is an amazing contraceptive method. It's been proven to be working. So when we look at this, we're talking about over 60% of women going through an abortion. Why? Because they don't want that pregnancy. Give them a condom. Next. Okay, if you give women a condom and you put it in the contraceptive mix, what do you get? A rumble. They have choices. A group would choose this, another one this, another one this, and some are using my condoms. Purple. Give adolescent a choice. And what do we have? Every single region is showing you that adolescent girl that is sexually active. There is an American study showing that 97% of the adolescents have used a condom as a contraceptive method. If you look at every region, even in the conservative ones, pink. You see this color? They condomize. Give them a condom. What does it mean for the boys? They're also sexually active. I'm going to get back to that. The girl is, we're measuring, We need to measure for boys as well. Please go. So, condom for STIs, the topic of the day. Go. We have over 1 billion people living with an STIs. We talk about the curable one. Every day there is 1 million new cases. They can be cured. You have to just go for it. I'm not going to talk about the asymptomatic nature of it because Mary addressed it beautifully. But we're also talking about HSV too, guys. It can transmit STIs. We're talking about HPV. 300 million people are having a human papillomavirus. Add that into the number. We are Africa, so we know about Zika, we know about Ebola. They can pass through sex. We have 2 vaccines, HPV and hepatitis B vaccine. Are we using them? They're over 96% effective. Are we using them? We're not. We're dreaming about an HIV vaccine. These are here. Use them. Our girls are not vaccinated. In the US, they're even vaccinating the boys. So, think about it. We can continue to dream, but let's look into what we have today and let's use them next. So, this is not something I'm going to talk about, but because Theo already mentioned it. The vaccines, the treatment that we have available, the antibiotics, some of them are highly resistant. We can go, it was addressed. The consequences of STIs, so many of them, so many of them. Somebody, the young girl mentioned about a boy that died from it. But you might not die from it, but you can experience infertility. When you're pregnant, you can lose your baby. When the baby is born, it can be born blind. It can be born with a very small weight. Just to think about it. Syphilis can go through your heart, through your brain. Are you getting me? So I'm talking a lot, but let's do a picture. Let's go. Okay? They said a picture is better than 1,000 words. Let's do it. They're dark, but do you see this? This is somebody hurting. When I have a just little cut on my finger, I feel the pain. This is human being, guys. Please go. Continue. This is almost nothing, it's just something that is abnormal. But it can go into something worse. Are you saying this, guys? It's the same for men and for women, and for the young girl and the young boy. Now go down. And if you don't do it for ourselves, let's think about the babies. They have nothing to do with that. Yet they will be born with an STI. And they will die. So, what shall we do? Okay, what shall we do to be saved? Like the Bible said. Okay, use a condom, right? Okay, before I get to the condom, let's go. Okay. Just abstain. Abstain, don't have sex. 100% of the time, you will be protected from an STI. Secondly, of course, abstinence has a deadline. There is a moment, okay, we got to move on. So you gotta find yourself in a relationship. Use monogamous. Be faithful to each other. Make sure that you don't have an STIs and be faithful in your relationship. Okay, I can just talk about condom, but I have to be realistic. This is reality. Next. Then, of course, hey, circumcision is good. Huh? You cut it and then it works 60% of the time. One time intervention and you have this protection. For we women, it's also not bad. We can have protection for HIV and all of these STIs and directly. So let's make sure that our boys and encourage our men to go through this circumcision. West Africa does it very well. The Southern Africa, consider it. And now it's not even that painful. It's not even painful because Theodora might talk about it, but there are new devices. So let's consider circumcision. And finally, of course, don't compromise. You have to compromise. So, ladies, let's not expect a man to put a condom in his body so that we will be protected. Use your female condoms. Ask for your female condoms. If you don't, it's because of you. So the logisticians over there, doing the planning, the quantification at the Ministry of Health. They won't think female condom. You have to do something about it so that the female condom is equally provided as male condoms.
Yeah.
If you don't, that's it. For the men, I'm done. You have condoms in all sizes, 49 millimeters to all the way to 56. So if your child, when we do statistics, we see that the young children are sexually active. Their body is small. They need a 45 millimeters condoms. Give that to them until they grow fuller as a man, and then they start using 53 millimeter condom. And if you happen to be really gifted by God and you have a bad big thing, sorry, use a 50 millimeter condoms. So don't compromise, condomize.
Condomize, condomize, condomize. Thank you, Lydia, for that talk. Now, just to go. Yes, you can go. Let me invite the last speaker. This is Natukunda Diane, who is the Executive Director of Women's Organization Network of Human Rights Advocacy, to give us some insight from a sex worker perspective. So Diane, you have 4 minutes.
Good afternoon, everyone. Good afternoon. I have no presentation. I happen in a conference as sex workers happen everywhere. I have a few minutes. I'm just going to give an insight of sex workers within the STI component in Uganda. As sex workers, our entry in health services is through HIV testing services. And when sex workers turn up for HIV testing services, we are interested in STI screening and treatment. When sex workers turn up for HIV testing services and sex workers don't access STI treatment and screening, we get disappointed as sex workers. And that means we will never come back for the HIV testing services. After turning a positive STI test, sex workers expect medicine. However, STI medicines are often out of stock in our country, and that's Uganda. And my call is to Ministry of Health should integrate STI treatment in HIV care. Some drugs that are available for STI have developed drug resistance among the sex workers, and the major gap in the STI management. And again, I call the donors available and our government as Uganda to always give better drugs for STI treatment. Although WONETHA is Women Organization Network for Human Rights Advocacy, and this is a sex work-led managed sex work in Uganda, and WONETHA distributes condoms in the whole country among sex workers. But as we know, condoms are not 100%, although we condomize. So we always face a challenge of condom bust, and this is because we lack lubricants as sex workers in the country. So Madam Condomize, please consider lubricants as a key issue in preventing STIs. So I call upon the government of Uganda to take this as a public concern, not a sex work concern, because having lubricants does not mean that we are promoting morality in the country, but it is a STI prevention and HIV prevention method. This should also be noted that sexual gender violence happens among sex workers. And where there is sexual gender-based violence, condom use is a myth. So we should also consider the sexual gender violence. Therefore, the occurrence of STI among sex workers cannot be ruled out. The poor management of STIs among sex workers will affect the entire community. And this should be taken as a public issue, not a sex work issue. As I conclude, we cannot end HIV/AIDS when we ignore STIs. Thank you.
Thank you, Madam Diane. Wonderful, very, very useful messages for prevention and control of STIs. Now, let me open up for a few questions. This is the first hand, second, third. Can we get the 3 questions? Yes.
Can all the presenters back up onto the stage so they can ask the questions?
Sure.
And
The presenters, please, if you can come back here.
And when you ask your question, just let us know who your question is directed to.
There's a hand there. Be brief with your question, right?
Thank you very much for the great presentations. I have 2 very brief questions. My name is Chido Ziwachkwadi from the Biomedical Research and Training Institute in Zimbabwe, and we are delivering sexual and reproductive health services for young people in the community. And my question is for Natasha and the condom lady. So in Zimbabwe and in our setting, the uptake of the female condom is very, very low. In fact, our young people said they don't want the female condom at all. And so my question is, what innovations are you or are people coming up with to make the female condom something that's more acceptable to our populations? My second question, which is directed to Natasha and probably everybody from the WHO, is that while we are advocating for STI screening, what we found is that our young people are actually not aware of their risk for STIs. They don't think they're at risk. We are offering non-syndromic screening of STI in the community, but our uptake is extremely low. So when you come up with these policies and strategies to make it available at point of care, do you have other strategies about how we can spread information to actually increase uptake of the testing? Thank you.
There was another question there. Let us take 3 and then allow the presenters to respond.
Thank you very much. My name is Kolema Mbisana from South Africa. I think it's more frustration than a question, because we all know about asymptomatic STIs. We all know about the issues among women, and we know that what we need to do is to screen, using what we have now, nets. But the question is, what is it going to take for somebody to say, what we have right now is gene expert. So let's identify populations that we're going to screen. If we want to screen pregnant women, that's a captured population. Let's get them screened whenever they come to the clinic, whatever many times. We've got male MSMs, let's screen them. We've been preaching this for years. When are we going to act?
Thank you. Take the last one.
Thank you very much. My first question is directed to WHO. I just want to find out how best can we make sure that the issue of integration extends to donors? Because most of the time you find that even their funding is tagged, they are mostly tagged towards a certain intervention. So it becomes very difficult, no matter how hard you try as a country, to organize the integration from program level up to service delivery level. So how do we get our donors to integrate, to help us with the integration? Then the second one goes to Kenya. I just want to find out how you deal with the stigma associated with separating STI clinics from the mainstream clinics, because for us as Swaziland, we went back to integration because people were not using the STI clinics because of stigma. Thank you.
Yes, Andrew Bull from WHO. I mean, it's great to see that just today we have 3 sessions on STIs. So it's great to see that STIs is being elevated to a higher level within these conferences. Just to let you know that within WHO, STIs is moving to the HIV and hepatitis program so that it will also be elevated in our agenda. I just want to raise an issue. Just last month, WHO had a global consultation on HTLV1, and we know that HTLV1 is endemic in quite a few countries within the region, but really very little is known about it. There's very little screening and almost no treatment available for very severe complications of HTLV1 infection. There was a plea from the representatives from African countries at this consultation to please include HTLV1 within STI programs in the region. And this plea also came from people living with HTLV1, which find themselves ignored by most programs. So thank you.
Okay, presenters, please, can you respond to the questions?
Female condom is a great commodity. Female condom is a device. There is nothing in this earth that we would start using without really knowing about it. You cannot just say that you put this in a community and they're gonna start knowing about it, using. They need you to accompany the community. When we have done that, we have story. Female condom was not invented yesterday. So we know from the past. And I was leading the female condom for UNFPA from 2005 until 2012 or something like that. I took it at the level when it was only 11 million female condom being distributed to 19 the following years, 19 million to 33 to 50. And then the program was taken away from me and put into the country. But I was doing it and it was successful because we were a team. We were motivated to do everything it took for the women to have their devices, to know about it, and to know that their body is theirs to control and to make sure that they know how to negotiate it. If you don't do that, you can put every kind of plastic you want. Nobody's gonna use it. So as you demand your female condom, demand the money to program it. I just wanna address one tiny thing, lubricants. Lubricant is a big thing. It has nothing to do with prevention, of course, but it's been proven from several studies that because it is no specification, everybody stand up and just produce what they call a lubricant. Some of them are increasing STIs. So as a group, we gathered and we created the first specification on lubricants that we sent to WHO, and we're waiting for WHO to finalize the review before we put into the market the first safe and non-toxic lubricant. Until then, whatever is in the market is not something that is really safe.
Thank you, Bidia. And Natasha?
Okay, so thank you very much. I love the question that you asked because young people really are not as aware as they ought to be about how much at risk they are of contracting STIs. But you know, there's also another issue to address, and working with young people, I'm going to do this out of experience. I'll answer this question out of experience. I remember talking to a group of guys, and we were talking about STIs and everything, and it was a community meeting. And for some of them, they do know that they're experiencing STIs, they do know that these are infections and diseases, and they do know when they came about, but then they just can't come out because that would mean, like, you know, it's a shameful thing. Why would you want to come out about having sex and then getting sick afterwards? That for them is really shameful for some of them. And then for other people, it's just they are not open enough and they don't even know where to go. Because they are really aware that the services may be said that the services are available, but they can't really access them as readily as they want to. So why open up to a community health worker who might not be so friendly with you, and then you even go there, but there's even nothing really readily available to be a solution to that problem. And for some of them, they don't even realize how big of a problem it is. For some of them, it's just, oh, it's just an age, or it's just discharge, it's probably normal. And I really love that you brought that out. And one of the key things that we can do is, I emphasize this because I feel sometimes we ignore this. One time back in Zambia, back home, there was a campaign that went around circumcision. And we used media, you know, we used influential people, we had musicians, and they were talking about circumcision on adverts, and they would do role play about what circumcision can do new, and before we knew it, records went high on the number of boys and men who actually went for circumcision, simply because of that period and that campaign. So sometimes we don't realize just how, one, champions who are actually influential in communities are, and secondly, how important the media can be in shaping people's minds on certain things. Use the media, use someone influential to actually, imagine having someone like Beyonce coming up and then talking to girls and telling them that STIs are actually a real thing and you can be infected and it doesn't matter as long as you've had sex, you're at risk. Imagine someone that big doing that, using the media, even producing a song about it. Being creative with young people is something we should never forget. Creativity attracts and draws them. Yes, wait, I haven't concluded yet. And then also, the other thing I really want to talk about is how peer-to-peer engagement and education, yes, I know. But then it's really important that these things come out, because if not here, then where? And so one thing we need to talk about is peer-to-peer engagement and education. Young people themselves should be able to have discussions about this. But then, for instance, I can go in a community and talk to people about this because I am knowledgeable, I know. But how many young people are Natasha Mwansas? So it's important that we actually invest and they can actually engage with everyone around them. But also, they should be able to get this information at all levels, from homes, to schools, to churches, to everywhere where young people are found. This information should be available. Otherwise, then there's nowhere we're going. So it's very important that we can access and have conversations about it at any time. Sorry, I'm a young person, I have a lot to say.
And we do appreciate you, Natasha. Thank you so much for that. I'll answer the question regarding the STI clinics in the country, in Kenya. First, I think I want to put very clearly that, you know that we have, before we used to have STI clinics, but we do not have, that they were, the ones which are existent, there are not so many within the public health systems. They're very few. However, we have some which are separated away from the public health facilities that are existent. So with the ones within the hospitals right now, they're very, very few. The same thing that you have highlighted, stigma and discrimination. So we are still struggling with that in the country. That is why we have integrated STI within the system that we have within the country, that's FP clinics, even within the CCC clinics. But we don't want it as well to be separate because of the stigma and discrimination. Even what we have highlighted on the data we have, it's within like the PrEP clinics that the screening is happening, not that it is separate. We have the same challenge as well in Kenya. Thank you.
Thank you, Catherine. I think we need to conclude. We have taken already 15 minutes of the next session. So other colleagues that are actually waiting. Let me conclude this session by thanking everybody really for participating. But really there are some key messages that we need to move out of this room with. Number one, we need to invest in STI care. We need to integrate the STI services into the existing programs. Also, we have the global strategy for STIs. We have tools that we should be using for integration. I'm sure they're available on our WHO website. But also, another key issue, we need to engage young people. Make sure young people are on board in the response of STIs. Condomize in terms of preventing STIs. And also, use of gene experts. They are available for TB. They can actually also be used for diagnosis of the STIs. So I thank you so much. I would request the presenters to have a group photo before you leave. And I wish you the good next sessions.